We now move on to our next session, a Meet the Expert discussion that delves into the complexities of osteoporosis management. May I now invite Dr. Priyankara Jayawardena and Dr. Ushani Varya Peruma to chair the session.
Good morning. Welcome to the Meet the Experts session. Our topic is today osteoporosis uncovered, challenges in diagnosis and treatment. We have an expert, eminent speaker, Professor SLCIM, to speak on this topic today. I don't think he needs a formal introduction to this audience. He's the authority in this topic in Sri Lanka, and his name is among the world experts in the field of osteoporosis. So I would like to invite Professor SLCIM to talk on challenges in diagnosis and treatment of osteoporosis. Over to you, sir.
Good morning, everybody. Thank you, Priyankara, for the nice remarks. And what I'm trying to do with the next 25 minutes or so is to highlight some of the recent developments in the field of osteoporosis. Since the time is very limited, I think I need to move very fast. The areas that I wish to cover in my topic, in my lecture, is the osteoporosis management in the era of the treat to target, a new concept which has crept into the management of osteoporosis. And also how the diagnosis of osteoporosis has expanded beyond the T-scores, and also about the FRAX adjustments, which have been introduced recently, and also the newer version of the FRAX, what is called FRAX Plus. So I have no disclosures. Treat to target is also known as the treat to goal or the goal-directed treatment. It's not anything new really, but it is the treatment decisions are made according to the likelihood of achieving the measure of composite measure or composite of measures. I mean, maybe just one target or maybe composite of targets that represent the treatment success. So you're keeping your treatment success or the target keeping that in mind while you are making your treatment decisions. So that's basically treat to target. Now, how that is applied to the field of osteoporosis? We know osteoporosis is a chronic disease where the fracture is the major clinical outcome. So whatever the target here is what is called the fracture. So what we are trying our best is to prevent fracture in this patient. So the fracture risk increases with age, just like diabetes, hypertension, and then the risk increases with age. This probably indicating that there should be a lifelong treatment, not treatment that you stop after 5 years and then forget about the whole thing. And also fracture risk is individual. We will let you know how it's become individual. So the treatment, the management part also should be individualized. However, there are plenty of uncertainties. How much reduction of fracture risk is desirable? And where you leave the patient at that particular fracture risk, and that is desirable, and whether we can achieve it. So what is the fracture risk that is desirable and also achievable for that particular patient? And also, how can we best assess the reduction of fracture risk with the treatment? Do we have a kind of yardstick that is, let's say, robust and also accurately reflecting the current fracture risk at the end of the treatment, where you can safely leave the patient without any treatment? Do we have that? How fast we can get there? Because some people, they need very fast, because it's not that you're going to have anti-fracture efficacy at the end of 3 years or under 5 years or something like that, because you need it now. Within first 6 months of the treatment, you need to have anti-fracture efficacy. Can we get there? And how can we use all this information to individualize the treatment plan? Now, let's have a little comparison between the standard care and the treat target in osteoporosis. So when you say standard care, the aim is to stabilize or increase bone mineral density. And of course, there shouldn't be a fracture while on treatment. So when you say stability or increase in bone mineral density, there's no quantification. But if you had, let's say, a substantial or significant increase on the bone mineral density from the baseline, then the clinician would be happy. And this is what's called the significant or the substantial increase is defined by what is called least significant change of bone mineral density, a concept which is a bit complicated, but I'm not going to drill into that now. So if the clinician felt that the patient's bone mineral density has increased from the baseline, and also patient has not had fracture while on treatment, I think that was a standard care, clinician can be happy. So you begin with the low-cost treatment, maybe oral bisphosphonate, and if there are contraindications, side effects, or no response, then of course you change to another low-cost treatment, maybe just solidonic acid, IV solidonic acid. But if the step 2 also fails, then of course you are thinking of more potent antiresorptives or anabolic, maybe just denosumab or teriparatide. So that goes as what's called a step-wise kind of approach in order to manage patient. But what is the treat target? So you are trying to achieve a target level of bone mineral density, not just a bone mineral density, target level, which is of course measured by T-score. So you're keeping a particular T-score in mind when you're starting treatment of that patient at the very early stage. And of course, there shouldn't be a fracture. So decide on treatment target at the baseline, what should be the target. And the initial therapy is selected based on what is called the baseline fracture risk, and also the time taken to reach the target. And also it's more aggressive, is an aggressive approach, and also with a more potent medication first. So there will be regular monitoring to stop, continue, or change medication. So you can see that there's quite a big difference between what is called standard care and the treat target. Now, steps involve the treat target. Again, just to summarize it, there should be risk categorization at the baseline. You should know what the exact risk of that patient. And also, you should identify what are the targets you are going to achieve at the end of treatment. And select the best treatment option or treatment options in order to get there. So you're going to align all three, your risk at the base, the target you're keeping, that you're focusing in the treatment, at the end of the treatment, and also your management, your medications, you align all of them together in order to get what is called T to target in osteoporosis. Right, now we need to determine the fracture risk at the baseline. That's the first thing to do. So what are the measures that we do have at the moment? One thing is what are called major and minor factors. The major factors include a prevalent or incident fracture. Prevalent fracture is a fracture which has happened in the past. The incidence fracture is a fracture of a new one, new fracture. We also have a bone mineral density. We use a T-score for that. And also we have got various algorithms which can assess the fracture risk with clinical incorporation, clinical risk factors. And the best one that we have at the moment is what's called FRAX. And most of the people know about the FRAX, and you can determine the fracture risk. So we have fracture risk, the T-score, and also we have a fracture as a yardsticks to measure the fracture risk at the baseline. We also do have the age, frailty, falls, and use of medication that can cause poor bone health. There are also what are called the minor factors that comes in the help making the decision. I'm not going to go through the contents of this slide, just to highlight that fracture anywhere, like the vertebral fracture, hip fracture, or fracture anywhere in the body, are the major predictors of the fractures to occur. So that's basically put it as a fracture begets a fracture. So if you get vertebral fracture, hip fracture, or any fracture, and your risk of getting another fracture is very high. So that is been proven and in numerous times. And also some authorities, they combine a bone mineral density and the fracture in order to categorize baseline risk. Now, the best one is what is called US NOF, National Osteoporosis Foundation guidelines. Now, these guidelines are basically for the USA. I will have another slide, the limitation of these particular guidelines outside the USA. Now, in the USA, a pharmacologic treatment is considered for any postmenopausal woman or a man who is older than 50 years if they have the following. The first thing is if they happen to have a T-score minus 2.5 in one of those sites, the skeletal sites. So if they have basically osteoporosis, and then they are treated. And also if they have got a low trauma spine of the hip fracture, and regardless of the bone mineral density, they are treated, because that's quite sufficient to start treatment. But if they had a low energy fracture anywhere else, non-hip or non-spine, just a head of the humerus or pelvis or a distal forearm, then the patient need to have a bone mineral density in the osteopenic range. And also similarly, the patient in the osteopenic range who has a high risk of fracture assessed by the FRAX, and also that patient should be treated. So this is a good example where the fracture as well as a bone mineral density are combined in order to assess the risk of fracture. But having said that, I just want to highlight how the US guidelines should not be applied outside the USA. It's common because when you go, let's say, Asian countries, and particularly it's some people in Sri Lanka, they believe in this, what is called NOF guidelines as a gospel truth. But it is actually based on the economic evaluation in the USA. So what has gone into this economic model in the USA are the economic data of the USA. So no other country can match it. And also they believe that the access to DEXA is unrestricted. So they do DEXA first and then they do FRAX next. So that again, most of the countries in the Asian countries can't do that. So that this model would not work in Sri Lanka. And also it happens in the country where the DEXA indications are very strict. Not like in, let's say, not like in our setup, where a 50-year-old woman who has got a backache for 20 years, walks into a hospital and seen by a doctor and get a DEXA scan. And that doesn't happen in the USA because USA would not reimburse that money, the insurance companies, because you have to adhere to what are called the indication for DEXA. So most of the irregular, let's say, irrelevant and unnecessary DEXAs are not done in those countries. And the FRAX is a USA model. And the ITs, the intervention thresholds, the 20% and the 30% they're talking about are applicable only for the USA. Just to tell you that those recommendations should not be applied outside the USA. Now, this is a National Osteoporosis Guidelines group in the UK, and where they are using what is called the FRAX. Now, this is a little more kind of logical and a more reliable approach because they go on the assumption that they know in the UK the access to DEXA is very patchy. In certain situations where the access to DEXA is very good, but there are certain areas where the access to DEXA is not very easy. So as a result of that, they go with what is called the evaluation of the fracture risk based on the UK FRAX model. So based on the UK FRAX model, and they can identify the person who has got a very high risk of fracture, who can be sent immediate for the specialist care, and the patient who has got a high risk of fracture, who can be treated, and also a patient who can be left alone. And also you can identify people who will need a DEXA evaluation because they are small in numbers when you apply kind of thing like that. So we have got a fracture, a bone mineral density, as well as the FRAX determined fracture risk in order to determine the baseline fracture risk. So based on that, we can have a stratification of the fracture risk. You can categorize people to very high fracture risk, and also what's called imminent fracture risk, which has come recently into the treatment arena. Let's look at the people who are the people who have got a very high fracture risk. People who have got a recent fracture within 12 months, people who have multiple fractures at the baseline, and also patient had incident fracture while on osteoporosis treatment, and people who have got a fracture while on treatment, receiving treatment for the like glucocorticoids and or maybe chemotherapy, who have got a high risk of fracture based on the FRAX evaluation, T-score minus 3.0, in some say minus 3.5. People with a history of injurious falls, high risk of falls, advanced age, frailty, and who are taking glucocorticoids more than 7.5 milligram per day. So these are the people, these are the criteria to define people or identify people who have got a very high risk of fracture. And then we have what's called imminent fracture risk. Those are the people who have got a more than 20% of risk of fracture within next 2 years. We know that it is very much like a myocardial infarction. If someone has got a myocardial infarction, the risk of getting a second myocardial infarction is very high initially, and the risk sort of, is reduced as gradually wanes off as the time goes by. So similar in the osteoporosis, somebody had a fracture, the risk of getting a second fracture is very high within the next 2 years. So people recognize that as what is called the imminent fracture risk zone. So people has a recent fracture within last 2 years, and the people have got, let's say, multiple fractures, particularly more than 3 fractures, vertebral fractures. They do have what is called the high risk of fracture, more than 20% within next 2 years. And they are where the rapidity of the bone mineral density gain is really required, because you need to raise their bone mineral density very quickly, very during the first 6 months or so. Now, monitoring treatment, and the goal of treatment is to prevent a fracture. So that is what basically we feel we're trying to do. The fragility fracture incidence is very low anyway. So because we know that when you look at what is called the clinical trials and look at the placebo arm, and then you find that they are not developing that many fractures, because it's the risk of fracture, the developing fracture, incidence of fracture is low. And that is why the clinical trials include people not osteoporosis, and they include people with osteoporosis plus multiple vertebral fractures in their clinical what I call clinical trials. And because the investigator need these patients to develop fractures while on treatment, and then otherwise you can't run their statistical models, so if they don't develop fractures. So we know that when you look at their data, that the incidence of fracture is low, so that cannot be, without not having a fracture, cannot be taken as an efficacy of treatment. And also, occurrence of just one fracture while on treatment cannot be taken as a treatment failure. Because let's say you start treatment and the patient had a fall and 3 months later and get a fracture. Now, no way that you can define that as a treatment failure, because that patient had a treatment only for 3 months and not enough time for the patient to increase bone mineral density that would not sort of prevent a fracture. And also, the use of surrogates such as BMD is where the BMD become very useful. So we know the BMD testing in treated patient can aid monitoring response to treatment and should be performed if the fracture has occurred or new risk factors have developed, and also when you're trying to stop the treatment or you change the treatment, and then bone mineral density should be done. What is the problem with the bone mineral density? We know that one standard deviation reduction of the bone mineral density doesn't work here. Okay. Anyway, the one standard deviation reduction of the bone mineral density here, we know the risk of fracture is increased by 2-fold. That's quite a standard statement. So one standard deviation reduction of bone mineral density, and then you increase risk of fracture. So you believe that if you had a increased bone mineral density by, thank you. If you increase bone mineral density by 1 standard deviation, and there should be a 50% reduction of the fracture risk. So that is, you turn that statement kind of, argument other way around. But we know that in clinical trials, a 0.5 reduction of the half standard deviation reduction of the bone mineral density, increased bone mineral density, a difference, and then there's be 50% reduction of the fracture risk. So in this one, 0.1 standard deviation improvement of the bone mineral density, and there was a 48% reduction of fracture risk. You know, to say that the bone mineral density changes are not actually, or let's say, are not parallel with the reduction of fracture risk. So fracture risk reduction is not mirrored in the bone mineral density change because they don't go parallel. But then we know clinical studies, if you had a higher bone mineral density difference with the treatment, and then there was a higher reduction of fracture risk. So if you gain more bone mineral density, and the fracture risk reduction was greater, so that much we know. So treatment targets for those with high fracture risk, let's say there shouldn't be a fracture while on treatment. Patient should not have a fracture. But if the initial T-score was lower than minus 2.5, and you are trying to achieve a T-score greater than minus 2, either in the total hip or in the femoral neck. The total hip is better than femoral neck because there are various technical reasons, so we generally consider total hip is better. But if the patient has a high risk of vertebral fracture and try to achieve a lumbar spine T-score greater than minus 2.0. So if the patient had a lower than 2.5 T-score at the baseline, try to get it at least more than 2.0 in one of those sites. But if the patient was selected, when the patient was selected here, the T-score above 2.5, let's say in the osteopenic range, then you are reaching, they are trying to get a T-score of greater than minus 1.0 in the total hip of the femoral neck. The initial fracture risk was high, then of course try to achieve risk below the intervention thresholds. Just to summarize that again. So if the selection criteria was a fracture at the baseline, treatment target should be no fracture. If the selection criteria at the baseline was T-score lower than minus 2.5, and then treatment target should be a T-score above minus 2.0. If the T-score was greater than minus 2.5 at the baseline, then you are looking at the T-score greater than minus 1.0 at the end of the treatment. And also, if the patient was picked up on the basis of the fracture risk, which was above the intervention threshold, then you are looking to go below the intervention threshold assessed by at the end of the treatment. Right. Treatment targets of those who have imminent fracture risk, because you need the rapidity. You have to get a bone mineral density rapidly increase, so higher bone mineral density gains initially. The selection of initial treatment. You are looking at the probability of achieving the treatment target within a reasonable period of time. Because in patient with the, let's say, imminent fracture risk, you are trying to achieve within, let's say, 1 year. But in other patient, if you're trying to achieve within, let's say, 3 years, that can be okay. Some needs more rapid gains, very high risk at the baseline, like you need sequential therapy. I'll come to that later. And then there's a question with the anabolic first or the anti-resorptive first, and then this debate goes on. But we know when the anabolics are given first, and then followed by anti-resorptives, and then they get a higher bone mineral density, and they're trying to sustain those higher bone mineral density. Stopping treatment when targets are not achieved, unlikely to be achieved, you consider sequential therapy. And also when the targets are achieved, then of course you decide either to continue treatment or discontinue, maybe intermittent treatment, or maybe we withdraw the treatment, so when the treatment is achieved. We published this what I call Asia-Pacific Consensus on Long-Term and Sequential Therapy Osteoporosis. I think it was published last year. Yeah, published last year this was. What the recommendation we gave? For people with at high fracture risk, anabolic agents are recommended as a first-line treatment. Injectable anti-resorptives agents can be prescribed as alternative anabolics, like we are talking about the denosumab. Anti-resorptive agents should be prescribed after completion of the anabolic therapy as a sequential therapy. So anti-resorptives are followed by anabolic treatment. Anabolic therapy should be considered for the people who develop new fractures or who have ongoing high fracture risk despite anti-resorptives. When the anti-resorptives are failing, anti-resorptives are not working, then of course you are thinking of anabolic treatment. Switching to more potent bisphosphonate, denosumab, anabolic agent, is an option for people with inadequate response to initial anti-resorptive treatment. And also, bisphosphonate should be prescribed after stopping denosumab to prevent a rebound phenomenon. Because denosumab, the problem with denosumab is that denosumab is water soluble and get out of the body moment you stop treatment and the fractures return. So that patient should be covered with should be given either bisphosphonate would be the ideal drug to be given. Drug holidays following bisphosphonate therapy should be considered only for those who have achieved adequate increase on bone mineral density and remain fracture-free during the treatment. Denosumab is used increasingly now, but the fracture return after withdrawal of the treatment and the sequential therapy plan should be decided very early. And I just give a little clinical case for there are plenty of clinicians here. Let's say 76-year-old Ms. B presented with a back pain of 2 days duration, and she gives history of fall 3 years ago and had an injurious fall and previously well, not on meds, and her labs were normal. Spine radiograph showed this fracture. So what is the diagnosis? Oblique fragility fracture. But how many of us would be happy to say that she has got osteoporosis because we have not done a bone mineral density? Now, these are the newer kind of, the expansion of the osteoporosis criteria in the recent past. You know that you're familiar with the first one where the DEXA scan, DEXA has picked up somebody who has got a minus 2.0 in one of those skeletal sites, so that's comfortable. But if somebody has got the low energy spine or the hip fracture, and regardless of bone mineral density, and this patient got osteoporosis, so you can very, very confident say this patient got osteoporosis. But the patient has got either fracture anywhere else, and then patient has to have bone mineral density in the osteopenic range. And you don't have to have you have to have an osteopenic patient who has got a high risk of fracture, and by definition, that patient also can be considered to have osteoporosis. So when you write the report, you say Ms. B has osteoporosis with a prevalent vertebral fracture, and her risk of subsequent fracture is very high. Just FRAX limitation and the adjustment. There are plenty of the FRAX adjustments that are coming to the picture, and I'll just go to the summary of that. If the patient's actually FRAX is calibrated for pregnancy around 2.5 to 7.5, but the patient taking more than 7.5, you multiply your FRAX outcome by 1.5. And then you can increase the risk of fracture because for the adjusted for this thing. And the progesterone less than 2.5, you downgrade it, you multiply 0.8. The recurrent falls, you have to increase, get 30% increase. The diabetes, you replace rheumatoid arthritis, and then you tick instead of rheumatoid arthritis, you tick diabetes. And also Parkinson's disease, neurological disease, you replace rheumatoid arthritis. And I all said that these are the imminent risk. FRAX Plus is a kind of, a newer version of the FRAX, which has got rid of most of the limitation that the initial FRAX had, and it will account for the falls and also account for the dose of corticosteroid, a trabecular bone score that we measure, and all that. The summary is that the fracture risk is individual, and the treatment should be individualized. Assessment of baseline fracture risk and determination of treatment targets are very crucial. Different yardsticks are used for the above purposes, and the management plan should be made based on the baseline fracture risk and the treatment target, so both should be considered. Sequential therapy is often required. Most patients need actually sequential therapy. Diagnostic criteria of osteoporosis is becoming broader. It has become broader, and a FRAX output needs certain adjustments. Get patients and family involved in making the treatment plan. This is very important because when the treatment decisions are made, you need to get patient as well as family involved, what is called patient-centered care, in order to the treatment plan to be more effective. Thank you.
We can get one question for time permits.
Yeah, good question. The question actually, the fundamental this thing is that belief is that the fracture risk, occurrence of fractures is highly geographical variation, and because of that, the FRAX models are country specific. So we do have a Sri Lankan FRAX model, which we introduced in 2012, and much before some of the other Asian countries developed their FRAX models. And also we work out what are called the intervention thresholds for Sri Lanka, and which was published, I can't remember the year that we published it. And so we have a intervention thresholds based on the FRAX model for the Sri Lanka. So we have said if somebody have a FRAX, major osteoporotic fracture risk more than 9%, and also if the hip fracture risk is more than 3%, and then that patient requires treatment. So Sri Lankan FRAX model as well as the intervention threshold have been published. We published the intervention threshold way back, but then we had a modified, we upgraded that, we updated the intervention thresholds, and 9 and 3% are the current ones. You can't use the UK model or a USA model in order to treat poor patient because they are built on, FRAX models are built on different kind of data. So those data cannot be shared by another country. I hope that answers the question.
Okay. Thank you, sir, for the excellent presentation. I would invite my co-chair to hand over the certificate of appreciation to you.